Social anxiety disorder is a self-fulfilling prophecy. Also known as social phobia, SAD is a psychiatric disorder characterized by discomfort around social interaction and concern towards being negatively judged by others. When triggered, sufferers can recede into an endless stream of repetitive and self-critical thoughts. This creates the worry that others will notice their excessive nervousness and reject them, exacerbating their anxiety to levels of noticeable functional impairment. In order to escape constant stress, many people with SAD will isolate themselves and avoid social situations altogether. About 15 million Americans currently suffer from social anxiety, making it the fourth most prevalent psychiatric disorder in the nation. A shocking 36% of them reported having symptoms for more than 10 years before seeking professional help. That's 5,400,000 people, each suffering alone for more than a decade. It's no wonder SAD was once dubbed the neglected anxiety disorder. Until 1970, SAD was barely a blip on the American Psychiatric Association's radar. It was largely lumped into the broader category of what they called phobic disorders. This included agoraphobia, animal phobias, and every specific phobia in between. It was widely known under the name social phobia. In 1970, Isaac Marks broke new ground by splitting phobic disorders into two groups, internally and externally stimulated. Social phobia fell into the latter category. This model proved so effective that the APA integrated it into the third edition of the DSM by 1980, standardizing diagnosis of social phobia. In 1983, Florida State grad student Richard Heimberg became the first NIM-funded researcher to study treatment for social phobia. His research focused on finding reliable metrics for the severity of anxiety, as well as solidifying subtypes and symptoms of the disorder. His ultimate goal was to develop therapy for what he saw as a serious but widely ignored condition. He used two scales to quantify and qualify social phobics: the Social Interaction Anxiety Scale and the Social Phobia Scale. Both respectively measured the two distinct aspects of social anxiety: social interaction and performance situations. For the first time, these allowed Heimberg to distinguish between generalized social phobia associated with youth, more severe impairment, and frequent comorbidity with alcoholism and avoidant personality disorder, and specific public speaking or performance phobias. The first full cognitive behavioral model Heimberg published in 1997 laid out the mental process behind social anxiety in several steps. The fundamental notions were 1. Social phobics think that other people are prone to see them in a negative light, and 2. They prize positive feedback from others. When confronted with a social situation, social phobics will first focus mental resources on forming a mental image of their external selves and scanning for any threat around them. Their perception of threat comes from what they see as their audience's reaction deviating from what it should be. They use this to deduce how others see them. However, their skewed social standards make them perceive an increased likelihood of negative evaluation, which increases their anxiety. This worsens their negative self-image, causing the whole vicious cycle to begin again. To qualify as a mental disorder, social anxiety disorder must reflect a deeper biological problem in the brain. However, to point at one region of the brain as the singular cause would be to wrongly reduce an impossibly complex disorder. Decades of structural imaging studies have probed into the roots of the disorder and have found a network of abnormalities tied to social anxiety. Social phobic brains are more likely to have a smaller amygdala and hippocampus, faulty connections between the middle temporal gyrus and inferior occipital gyrus, thinner rostral anterior cingulate cortex, posterior cingulate, and temporal regions. But the amygdala is the most vital operative region in the disorder. The amygdala regulates emotion, memory, perception, and most importantly, fear response.
When you encounter sudden danger, you might freeze, your blood pressure and heart rate begin to rise, stress hormones are released. All these things happen as a result of outputs of the amygdala.
Social phobics have hypersensitive amygdalas that create threats where there are none, and jump into overdrive in threatening situations, such as public scrutiny. A 2013 study presented subjects with images of a range of facial expressions, negative and positive. Researchers monitored their brain activity and found that SAD patients carrying serotonin-linked high-response alleles had more amygdala activity when shown angry faces. The amygdala aberration increased their sensitivity to potential social conflict or threat.
Sorry. Excuse me.
PET studies also point to abnormal cerebral blood flow as a factor in the disorder. A 2002 study used PET imaging to observe patterns of CBF during public speaking in SAD and non-SAD subjects. They found that social anxiety was accompanied by enhanced CBF to the amygdaloid hippocampal region and the right dorsolateral prefrontal cortex. Other theories include the frontal and associative cortices, which perform cognition and executive functions. They may function at lower capacities when faced with complex social signals and fail to control that negative feedback loop.
Treatment for social anxiety disorder can involve varying combinations of psychological therapy and medication. Drugs often treat short-term symptoms, while psychotherapy targets the root of the problem to precipitate long-term improvement. Although therapy technique can depend on the professional counselor administering it, the two most common types are cognitive behavioral treatment and cognitive behavioral group therapy. One component of CBT is exposure treatment, in which the individual pinpoints a situation they fear, then either imagines or directly confronts it until they experience some degree of relief.
Ridiculous!
CBT has proven by far the most effective method of therapy for SAD across over 100 clinical trials and 40 treatment subtypes. CBGT is conducted as a 12-week course administered by 2 co-therapists to 6 participants. Their sessions also make use of exposure exercises, but with the addition of cognitive restructuring and frequent check-ins to voice thoughts and feelings throughout the process. In contrast to psychotherapy, pharmacological treatments go straight to the brain's biochemical pathways. Beta blockers stem the flow of epinephrine, briefly blocking physical symptoms of anxiety. Selective serotonin reuptake inhibitors, most commonly prescribed for depression, can also work for SAD by decreasing CBF to the amygdala and nearby parahippocampal regions. This dampens symptoms of anxiety and cuts off the negative feedback loop before it freewheels out of control.